Well, before I start the topic, on behalf of all of us, the medical fraternity, those who have attended this program, on behalf of all of us, there is a prayer for the departed souls of all Bharatiyas who lost their lives in the terrorist attack at Pahalgam, Kashmir. And there are two mantras for the departed souls. Either they go to Rudralok or they go to Vishnulok. So, Om Rudraya Namah, Om Vishnave Namah. So, this is the beginning before I start the topic. Well, before I start, I will clarify certain things. That there is a standard care and there is a limited care. Topic will be divided into standard means the ideal, like Dr. Urban. Limited care is Shailesh Trivedi, suppose. So this is the, there will be some difference here and there. In the scientific community itself, in the ADA itself, they have devised or they have coined the word standard care and limited care, number one. And number two, the treatment part, beneficial effects of insulin is fine. That is a part. My topic is. But it is like, Modi ji and Amit Shah, they can't be separated. So here, I would definitely touch partly a metformin. Metformin, which has beneficial effects. There are so many controversies which have been surrounded in the last, few years. That metformin is not good in GDM, no. But then I will try to clarify that also. If you see the diabetes is rising and India, the increase is from 70.4.2 million from 21 to 124.29 million by 2045. But so is the estimation for the Southeast Asia, where the increase is almost 28%. And out of, the word is very important, out of 1 in 4 births, live births, 1 is affected by hyperglycemia. I do not mean hyperglycemia means GDM only, hyperglycemic status. बैटरी खलास है कहीं नहीं रहवा दो चल it can happen to anyone. થાય તો ઠીક છે નહીં તો રહેવા દે બેટા આ ખાલી ચાલુ કરીએ આપણે. Before that is started, I must congratulate Dr. Urban Bhai for during his term RSSDI as a chairman. Apart from COVID, all programs have been handled so well. He is a true practical academician. Theoretically, he is too good, and organization wise also he has proved himself. So hats off to him and his team. Now the reins will be given to Dr. Sanjeev Phatak, who is also, like Amit Shah and Modi ji. They are like, hands in hands. And चलो उसको छोड़ो, मैं ऐसा ही बात करूँ. चलो हो गया, ठीक है. You see, one size, the topic is like this. One size does not fit all. Here, if you see, here is like Raj Kapoor. मेरा जूता है जापानी, पतलून है इंग्लिस्तानी. Here, the man has, 2 different type of shoes, and the child is trying to wear the different type of shoes, Similarly, in all patients, whether it is diabetes mellitus in adults or whether it is GDM, you have to tailor make the treatment. You have to individualize the treatment. That is the main goal of the topic. Look at you, Tarat. To lay you better. If you see why? Because basically first is resources are less. There is a limited test supplies of equipments and time consuming screening, and there are certain communities, there are cultural obstacles. Then there are certain beliefs that in pregnancy you can't take this, you can take this is like 3%. All said and done, the most important is here. 65% of the health professionals, I don't mean doctors, health professionals were unaware of GDM, leading to a lack of knowledge and motivation among the. Here at the first meeting, when the patient hears, the lady hears that she has developed diabetes mellitus, oh God, why have I developed diabetes? God has only selected me only. What was wrong with me? What sins did I do in the last years, last janma? So this is what the first feeling is. So you have to counsel her psychologically. For that, diabetes educator, good person, psychologist, and ultimately the things will come to you only as a doctor. So that is why you have to tailor make the treatment for everyone. Basically, the treatment management is, it requires a coordinated approach. And here our main aim is to minimize the maternal and neonatal morbidity by good glycemic control and healthy diet. Treatment is first to start with, in diabetes you start with diet followed by exercise. Here is a fancy word, medical nutritional therapy and physical therapy. It is safe. Followed by, it should be treated, but the trial should be given only for 2 weeks only. MNT and this physical therapy should be given for 2 weeks. Then, if 2 hours postprandial plasma glucose remains more than 120 milligram per deciliter, despite MNT and lifestyle, start with either insulin or metformin in limited situations. When it is more than, instead of 120, when it crosses 126 or 200 post glucose, but most important is 126, then you start insulin. Okay. Pre-existing diabetes, insulin requirements are very clear. Here, instead of remembering everything, remember the first trimester 0.7 units per kg. Pregnant women's weight 0.7 units per kg. Okay, 0.8 in second trimester and 0.9 in third trimester. And 38 weeks onwards, the dose of insulin increases to 1 unit per kg. This is a standard care, Urban Bhai. The insulin is preferred medication, everyone knows, but metformin and glyburide should not. Glyburide is American, here glibenclamide. It should not be used as first line agent. Now what about the one who is using metformin? Suppose there is a pre-existing diabetes. There is another medical condition where he was used. Now, then metformin when used to treat polycystic ovary syndrome, that is what I want to see, and include ovulation, which induces ovulation, and patient becomes pregnant. Then in the first trimester there is a organogenesis. Okay, so here at any cost you should see that she stops metformin and she switches over to insulin as early as possible, and then leave it to her. Whether she agrees to our line of action or not, that is her choice. Okay, and when insulin is not possible, feasible or acceptable, metformin may be used after 12 weeks of gestation, after this, because 12 weeks I say it is a embryogenesis. However, because of the metformin should not be used in women with certain conditions like hypertension, preeclampsia, prematurity, or at risk of intrauterine growth restriction, where insulin remains the drug of choice. It is a placental insufficiency. This is all placental insufficiency. It can happen in hypertension, it can happen in diabetes, it can happen in infection also. Limited care, Shailesh Trivedi. Insulin is the first drug. It can be started at any time during pregnancy. For GDM, if medical nutrition therapy fails, while it is not when patient is not willing at all, insulin use is not possible. Metformin can be recommended after discussing pros and cons. Fine, that I will come little later. Indian experience, our conception is hota hai, chalta hai. The previous speaker said that no one believes in the gynecologists, they would not like to change the protocol of the diagnosis, anything. So, if the patient is already pre-existing diabetes on metformin, then they would not like to change. This is what it is. So, however, hypoglycemia and weight gain with metformin are less in comparison to insulin. This is important. because the risk of prematurity is slightly increased with metformin. That one must remember. With metformin, prematurity is slightly increased, and if insulin is required in high doses, again here it is because insulin is going to grow and the patient is going to have baby is going to have a little more gain, but then you add metformin. So this is what insulin and metformin. Metformin has certain advantages, and all said and done, Government of India, Ministry of Health has endorsed unequivocally that metformin can be started, initiated, maintained till the last point. Remember this. But ideally, standard care, insulin. Then these are all contemporary, these are all trials. This is a MITI trial. This is a MIT-TOFU trial. MITI trial is in favor of use of metformin because of certain understanding that the result is it was implications of this effect on infants will be important in the future. Why? Because they resulted with fewer large infants, but a higher proportion of the babies were all of the smaller. While here the things were different, but till the age of 9, second trial, MIT-TOFU trial, till the age of 9, they were 7 to 9 years, they were okay. Metformin exposed children, then when they became around 9, they gained weight. So this is another, these are all latest trials. These I have taken from 2023 journals. Pregnancy outcomes. This is a ongoing trial where we are, right now also it is going on, where the things are included for both maternal and for the children, for the child. Hypertension, preeclampsia, other complications, fetal complications like shoulder, clavicle dislocation, including IUFD. The contemporary latest information GDM2, this is I think safe, which I said that it is a Ministry of Health, I already said, and this is important. NICE guideline also they are endorsed. And another trial which is a European study stated that metformin is safe for use throughout the pregnancy. So if patient is not agreeing to insulin, please see that you don't pressure upon him, don't enforce upon him. Fine. I am not against insulin, I am for. This is a typical algorithm. Pregnant woman, standard MNT, 2 hours postprandial should be done. If it is less than 120, fine, you are happy that your diet and everything has worked. More than 120, start pharmacotherapy. Standard care is insulin preferred, limited care, Shailesh Trivedi. If it's not possible, start insulin, start metformin after explaining pros and cons, which I already explained. But the biggest thing is, still I am going to give another big punching, another final nail in the coffin in favor of metformin. That 2024 Delhi Declaration of DIPSI, they very clearly mentioned. The aim is, I don't know whether Modi ji got the idea from him about the non-communicable diseases, because he has started running the campaign for obesity. But here that we did this in 2024 Delhi Declaration, the same. NCD is on a rise and Modi ji took it. And that was one of the declarations. There, metformin is recommended very strongly. 250 milligram twice a day. This is the individual insulin therapy. Pre-pregnancy BMI, if it is on higher side, please. Gestational weight gain, yes. Individual response to therapy resources, if a patient cannot afford, what can you do? Leave it. Intolerance to metformin. I have seen of late, I have almost 42 years of practice. I must have seen more than at least 12 lakhs of patients. And intolerance to metformin patient, of late I have seen whether the quality is deteriorated or whether SR or GR or immediate release, I don't know what is happening to pharma. What metformin I was seeing before years, now it is not there. Out of at least 20, 2 or 3 patients will always complain, "Sahib, leeda pachi, not comfortable. Some pet bhare the jai." And they start losing weight, or because of the loss of weight is because of the loss of appetite. This monitoring is very, very important. Ideally, 7 point, Urman bhai, 5 point, Shailesh Trivedi. 3 point, that means we are flexible. Point is, 3 point when? Fasting, pre-lunch, post-lunch 2 hours. The patient has to agree because it is costing. Okay, standard care. Insulin remains the gold standard for all women with GDM who fail to achieve the target glycemic control with MNT and exercise. Okay, insulin regime type and 1. Here remember one thing. No insulin is superior. Whether you take Lispro, whether you take Aspart, whether you take Fiast, whether you take simple human insulin R, Novorapid, whatever you take, or NPH, or all insulin analogs, equal results, they are equally good and equally bad. Only thing is good about the analogs is that chances of hypoglycemia is less, and number 1, it has immediate effect, and number 3, if by chance hypoglycemia happens, the chances are that it will be for a shorter duration of time. Insulin regimen is most important. When does it happen? Khada pachi થાય ને. So you start with a prandial insulin. In Germany, the protocol for standard treatment is this: prandial insulin therapy. They give 3 times insulin. They don't believe in all this. So before lunch, before breakfast, before lunch, and before dinner. If she agrees 3, otherwise if 2 times. So prandial insulin, if it is still fasting is on higher side, more than 126, then add bolus. So 1 is prandial, second is prandial, and second is added is bolus. Still on higher side, then, and weight gain is there, metformin. Insulin therapy. Here this is an Indian study that almost 45% of the patients, they ultimately landed maximum 2 minutes, 3 minutes. They ultimately required this, and FBG was this. Study showed that insulin requirement was this, and this is the study which I don't want to. Insulin therapy, which I should short, and this, which everything is same. How about the glargine? 5 minutes more से बता. Glargine has not been recommended, but European group of study, European Medical Agency EMA, they have given a political answer that 1000 continuous pregnancy observations have given the following outcome: that in none of the patients they develop any problem in the mother or in the fetus. So in short, they endorsed. And we here, suppose if my patient is there and she is already on glargine, then I would like to continue. I would not like to, because if I stop, hypoglycemic person. Pregnancy monitoring, 75432, as I mentioned, 10 to 2, that is also this. If visits for gynecologist, usually 4, 2 more added. Still 2 more added after the pregnancy. The last visit is after 6 weeks. That is very important. Insulin therapy, fasting. This is the crux of the story. The whole crux of the story is here. The recommendation to maintain fasting glucose should be, if we are happy with 100 mg%, no, we should not be happy with 95 also. We should be happy only when it is less than 90. So that is most important as per the ACOG. And our DIPSI guidelines, as Dr. Durban Bhai said right now, they are also with the same wavelength. Have I forgotten premix? No. If patient is already on premix, fine. The protocols are same. Again I said, only advantage and disadvantages are a little here or there, but you can monitor yourself. This is a prayer. Garbha rakshatu deva, ayam shishu nirogi bhavatu. So my prayer on behalf of all of us is, oh God, may the divine being protect the womb, that is mother's womb, and may this child be healthy. A prayer on behalf of all of us to GDM. Thank you. Right.